Okay, so everything we talked about yesterday was getting them from prepped to induced and now intubation. And again, um, you remember why we intubate is basically to more efficient delivery because it goes, it takes it through the oral cavity directly to the bifurcation of the trachea, which is closer to the lungs. So it's a more efficient delivery of anesthetic. So it bypasses, even though the tube does go through the oral cavity, technically the gases are going through the tube and they're not going through that cavity. So that's why they say it bypasses those structures. Now it says can be connected to an anesthetic machine to maintain anesthesia. Occasionally, I want to highlight this, and you guys might see this done on externship, and I mentioned this in a lecture before. Sometimes if I'm doing what's called TIVA, where I'm just doing propofol as, if I'm doing propofol as my anesthetic only, and say I just want to do an IV maintenance, but I have a patient I'm concerned about their airway, especially like a bulldog or, another brachycephalic, you can intubate an animal, tie the tube in, and not hook it up to anything. And then you have an airway that's protected. Like I would normally, if I do that, I will inflate the cuff so that they don't get any saliva that runs down their trachea, they don't get any potential vomiting or regurgitation. And then if that patient has a hard time breathing, I already have an airway established. So anytime you were to use, say you want to do an IV induction and an IV TIVA maintenance, you can intubate just in case. So I do that occasionally. So again, having an airway, and again, that tube needs to stay in until the swallow reflex occurs. We're going to talk about recovery of patients, but normally when we turn off the anesthetic or you stop giving the propofol, as soon as you're done and they start to regain consciousness, remember, they're going to now come from stage 3 and go through back to stage 1 and be awake. But we don't want to pull that endotracheal tube until their swallow reflex returns, because if you pull it prematurely, they can't cough, they can't swallow. So if they were to vomit or to regurgitate, or if they have a lot of excess saliva or anything in their mouth or throat, they can potentially aspirate. So you do want to keep that tube in until that time. So that's what the cuff, remember, the cuff prevents leakage of waste anesthetic gas. It prevents aspiration of contents. It does not hold the tube in place. You need to tie the tube to the top of the jaw. And in cats, we usually tie it behind the head, and that's what keeps the tube in. Because if you have to pull the tube quickly, you don't want it stuck where you can't get the tube out. So it's not meant to hold the tube in place. And the other big thing is remembering what is dead space. So anatomic dead space is any area of the respiratory tract where gas exchange does not occur. That's the nares, the nasopharynx, the trachea. It isn't until the gas gets into the bronchioles to the alveoli where gas exchange occurs. So if you can bring the gas closer, then you're decreasing all that dead space. If they were breathing through a mask, if you were using a mask for induction, they have to pull the gas all the way from the nasal area through the nasopharynx down the trachea. So they have all that area, which is called dead space, that they have to move the air. So again, it's more efficient. And the big thing here is you can ventilate your patient. Again, you cannot bag a patient with a mask on. And if an animal is not breathing and you have a mask on, they're not getting oxygen. Oxygen doesn't just creep in to their alveoli. They have to be inhaling. So, but with a mask and you squeeze the bag, you can't force the oxygen into the lungs. So, now, sometimes people will have a mask with an ambu bag and you're trying to get some air in, but if there's cardiac arrest or you need to ventilate your patient, you need a tube. So a review of the, anatomy is, here's the nasal passage. Remember, the hard palate is the roof of the mouth, and above that is the nasal passages. And that little space back here is called, if you remember, the pharynx is the common passageway for respiratory digestive structures. The top is called the nasopharynx, and the bottom is called the oropharynx. Now, the soft palate, which is not in this picture, would be hanging like a curtain back there. So normally, and then you've got the flap. This is an epiglottis, and normally the epiglottis covers the trachea. So sometimes when you go to intubate, that epiglottis is kind of stuck. You got to push it down and go over into the trachea. And the esophagus runs above the trachea. So things you need now, I will have to give you a separate chart of kind of like tube sizes. But what I usually recommend is you can take the tip of the tube that goes into the patient. So not the adapter that hooks up to the breathing system, but the beveled edge of the tube. And if you put it in between their nares and it fits between their nasal passages, that's roughly their tube. Or you can reach in their throat and feel. But the thing is they'll vary. Like cats are normally like a 3.5, usually I would say a 3 to a 4.5 endotracheal tube. I got a 5 and a Maine Coon one, so very big cat. But for the most part, that's where cats are. And then, your small dogs are kind of anywhere from a 6 to an 8. And then like Cocker Spaniel or, a smaller terrier might be like, or a beagle like 8 to 10. Boxers, it would be somewhere from 8 to 10. And then your labs, German Shepherds, might be like 12 to 14. The ones that are not based on body weight is your bulldogs, Frenchies, Bostons, because like I said, I had an 80-pound bulldog and he took like an 8 endotracheal tube. An 80-pound shepherd would probably take a 12 endotracheal tube. So body weight does not equate to tracheal size. And again, the brachycephalics, that's one of their other problems, is they usually have small tracheas based on their body weight. I had to put a 5 in a Frenchie once, and I just told you I put a 5 in a Maine Coon. So that just gives you an idea that sometimes, so normally what I do is I put out the tube that I think I want to use. If I think I want to use like an 8, I might put out a 7.5 and an 8.5. I usually put out 3 tubes. The one I think I'm going to use, one smaller, one bigger. That's kind of like and so it says, put out 3. And then one thing that you need to do before anesthesia, and this is a tip that you want to write down, is I lay out the tubes and then you want to fill their cups with air and let them sit, because you want to make sure that those cups aren't leaky. And so if you let them sit with air and then you come back in 10 minutes and one is deflated, then it had a leaky cuff. You can also inflate them in a bowl of water. You could just take a kennel bowl, like a water bowl, or if you have a tub in your surgery room, you can put the cuffs underwater and fill them. And if you see bubbles, they have a leak. So you need to test the cuffs before intubation to make sure that they're going to hold pressure. We usually have either some roll gauze and some gauze to grab the tongue. Well, here, it's easier to show you the picture. So this is what I usually set out. And the other thing that is a tip, I see a lot of people, sometimes people induce dogs on the floor. They leave them on the floor, and then, which drives me nuts, because then you're picking up dead weight. And I see people lay these tubes on the floor with dirt and hair, or sometimes people clip for a catheter, and then they put their tubes right where they clip the hair. And you're about to put this in an animal's trachea. If it was going in my trachea, I'd be like, that's disgusting. So you want to lay them on like a paper towel. At Michigan State, when I did my clerkship there, they had paper plates. and on the paper plate they wrote the name and they put all the drugs in the tube, and then that paper plate. I've seen people use food trays. I mean, something at school, you guys will have these little plastic trays, and that's where you put all your stuff. But when they're on a table, they need to be on a paper towel or something so they're not laying in any debris. But here you're going to have a gauze. And this letter B here, some people use IV tubing. They'll cut up IV tubing that's used, and they can use that as a tie. I'm not a fan. Some people use rubber bands. I think they can get too tight on the jaw. A syringe to inflate the cuff. Now this syringe is usually on the anesthetic machine. Usually there's a little holder where we keep a syringe, but you have to have a syringe so you can inflate and deflate the cuff. Now, what's special for cats here is that cats are prone to laryngospasm, and they need to have lidocaine. So normally what we'll do is we'll draw up no more than 1/10 of a cc. Let me go ahead and type that because if I could type this morning. And that's not a half cc. Cats are very sensitive to lidocaine systemically. So usually when we do local blocks in cats, they are sensitive. So you don't really need more than 0.1 cc's. So that's a very tiny, that's the very bottom kind of your syringe. Now, some people, there's lidocaine gel and there's lidocaine spray. Lidocaine gel I'm not a fan of because I think it makes them excess salivate, and you actually have to touch the vocal cords to apply it. And sometimes when you touch them, you're going to induce laryngospasm, and that means then their larynx will close. Some cats will actually turn blue and could potentially stop breathing. So, and that's specific for cats. We don't need to do that. When you size your tube, again, you want to pick the biggest tube you can because, again, you don't want to inflate the cuff, overinflate the cuff. And the length is, let me talk about what's called mechanical dead space. So I talked about anatomic dead space is obviously the anatomy of the animal. When you guys pick these tubes, they come as a predetermined length. And if you have a lot of tubes sticking out from the nose to the breathing system, that animal has to move that air all the way through that tube. So you want to try to use a tube that's short enough. And that's what mechanical dead space is, because that's areas where gas obviously is not, moving to the lungs. It's kind of caught up in all this extra space. So by choosing a tube that's of the appropriate length, that's going to minimize mechanical dead space. And then we want it to be at the thoracic inlet, but we don't want too much tube sticking out the end past their nose. And again, your patient, they are going to be a factor. Now, cats, the nice thing about cats is they're pretty universal. From the tip of their nose to their thoracic inlet is pretty much the same in almost every cat. You have a few cats that are bigger and smaller, but for the most part, they have about uniform sized tracheas and uniform length. When you get into dogs, we're talking a Boston Terrier versus a Greyhound. And a Greyhound has a very long snout and a very long neck. And so versus your Boston Terrier, everything is kind of compressed in. So in dogs, there's a wider range as far as, their conformation and their breed are going to be a little different than cats. And I'll tell you, horses are pretty universal. Cattle are universal. Pigs are pretty universal. It's kind of dogs that we see a lot of differences in as far as like size of trachea and length from the tip of the nose to the trachea. But let's look at a picture here. So here is the trachea, and here is the bifurcation. And so this is the ideal placement. You want to have the tip of the tube, and you can even probably put it a little bit closer, but you want to have the tip of the tube right before the bifurcation. Why do we want it above the bifurcation? Why do we want it in that spot?
So it goes to both the lungs equally, because isn't it possible if it goes to one, like the other may collapse or something?
Potentially, right. So if you look at picture B, this tube has been put in too far. And when you inflate the cuff, oxygen and anesthetic can't escape and get into this bronchus. Okay. So, so if you've got this, one side is going to the left side of the lungs, one side's going to the right, then this side of the lungs is not getting oxygen and anesthetic. So yes, they're potentially not going to expand. There's not going to be gas exchange. So those patients sometimes will turn a little blue. Sometimes they pant during anesthesia. Sometimes they have elevated CO2. So those are sometimes if I'm having trouble with a patient breathing, like bad color, bad SpO2, I'm battling CO2, a lot of times I'll feel under the drape and I'll feel the trachea and I'll slide my tube back and forth and I'll check my placement, because sometimes it can get accidentally pushed in too far. And this is a problem sometimes, when you guys go on externships, and you're going to sometimes deal with on-the-job trained people. And they may there's people that I used to work with this girl, and she just slid the tube all the way in. And she goes, well, it has to go all the way in so that the end is sticking out. And I'm like, no. And, she was arguing with me, and my boss finally backed me up. I was like, she doesn't, I was like, I'm sorry. I went to school. I know that there's a bifurcation. I know the anatomy. And no, you don't want to bury an endotracheal tube in an animal because you're going too far. Physiologically and anatomically, that is incorrect. So the reason, again, so you can see in this dog, you've got some tube sticking out right here, and then this is your breathing system. And then it's tied, it's secured. So what you do is when you intubate, you're going to feel the thoracic inlet and you're going to slide your tube back and forth. Now, the thoracic inlet is about where you guys hold off for a blood draw. So right where the jugular groove is, you got to reach in there and feel the rigid structure. That's the tube. That's the trachea with the tube in it. And when you slide the tube back and forth, you should be able to feel the tip of your tube. And then that's where you tie it. Now, I have also had people, if this dog was sedated on a table, some people will lay the tube kind of against the animal and measure and say, okay, the tip is right here at his jugular groove, and that's about at the 30 centimeter mark. And when they put it in, that's as far as they put it. You can do that too, but you're going to have to palpate the trachea anyway after intubation, and I'll explain why. So this is proper placement. So you have to know, obviously, the anatomy that you're looking at, the proper restraint positioning. I prefer to intubate animals in sternal recumbency. So a lot of times when they're sedated and you guys go to put the catheter in, sometimes these dogs are so sleepy they're laying on their side. I mean, I've had to intubate patients in lateral recumbency. I've had to intubate patients upside down. I mean, it can be done, but ideal intubation is done in sternal with their legs. And sometimes I see people lift up their head and then the dog is laying down, and then they just lift up the head like this to intubate. Well, the problem is then the neck is all twisted. It's just you guys will have enough people. Just get the dog or the cat completely in sternal recumbency, spread their front legs out, and then extend their head. And that's going to help open up the throat so that you can visualize. And you have to be able to visualize the larynx. If you can't see the larynx, you're not going to be able to intubate. So you need to have good lighting. And when they're induced, they should be ready when they lose their pedal reflex and they have loose jaw tone, and they should feel very relaxed, like they fall asleep in your arms. And then whoever is restraining for you, usually I have someone open the top jaw and I have them hold the tongue. And then I hold the laryngoscope in the tube. If we look here, so you've got the hard palate up here, you've got the soft palate right here, which is kind of hanging, and then there's the epiglottis. And in this picture, sometimes I will tell you guys, you'll open the mouth and someone goes, I don't see the trachea. Because sometimes the epiglottis gets stuck under the soft palate. It's called epiglottic entrapment. So sometimes the soft palate's long and the epiglottis. So what you do is, what I prefer to do is take my endotracheal tube and I can stick it back there and pull down the epiglottis. You can use your laryngoscope blade too, but the tube is less traumatic. So you don't cause, again, the tube, since it's like a soft plastic, it can reach back there and pull down the epiglottis. Then I use my laryngoscope to push down the base of the tongue. And then again, the epiglottis, you don't use the laryngoscope to hold down the epiglottis. I've heard some people say that, and you don't want to cause any trauma. And sometimes if they're a little light, that'll make them kind of fight intubation because something is holding their epiglottis. So I go back far with my laryngoscope. I push the base of the tongue. And when you pull the base of the tongue down, it will pull the larynx open. And then and that's where you're going to put your endotracheal tube, right here. Let me see if I can get this. I had put this video about intubation on here. So hopefully you can see this okay. And this is just talking about on the video. Don't forget to check your stuff. So this is kind of like the whole process of making sure that IV induction is ready. So, and it says right here, it says measure from the canine teeth to the point of the scapula. The point of the scapula is about even with the thoracic inlet, which I say to feel here about the front of this. Now, not every dog are you able to feel the scapula, but it's really the front of their shoulder. The most cranial aspect of their shoulder is where the scapula, and again, that's even usually with the thoracic inlet. And you can get an idea of how much tube will go in. So if you look here, they're just showing you that here's the point of the shoulder. But if you reach in here, which is the jugular groove, you'd be about that same spot. And then now, again, you may have a lot more tube. There are some dogs, let me just mention, there's some dogs that, like in a big old German Shepherd, I've pretty much put the whole tube in the animal because they're much longer. So there are some patients where the tube will almost go all the way in. I never put the adapter end completely in the mouth. The reason being, I've had dogs wake up prematurely and I've had to yank the tube out. And if they're chewing and the whole tube is in their mouth, you're not going to be able to get that tube. I always want to have a little bit of the tube that I can grab in an emergency. So I never, ever, ever put the entire endotracheal tube in the mouth. It's okay to be a little bit back here. I would rather be not as close to the bifurcation and have some tube out here in an emergency. So there will be situations in big dogs where you may have to put, the tube almost all the way in, but always leave yourself a little bit of tube to be able to grab in an emergency. So this is just giving you an idea of how to measure placement in the animal. So in this video here, so they're giving the alfaxin, and you can see they're kind of pushing it slowly, nice and sedated. I guess, oops. No, 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 no. Oh.
I couldn't see wonderfully because I have my glasses on, but are they putting that into an IV catheter?
Yes, so she's got the catheter here. And now they're checking the jaw tone just to see if he's ready. Yep. So it looks like he's pretty relaxed, but maybe she got a little bit of resistance. So sometimes, so now they're just giving a little bit more. And so again, I usually, and this is all different. Sometimes the person intubating, when you get good, you can hold the tongue and the laryngoscope at the same time. I usually have the person restraining hold the tongue. But this is what you're looking at. So what you're looking at here anatomically, this little thing right here, like a curtain, that's the soft palate. This is the epiglottis, which is down. You've got the arytenoid cartilages, or this is the larynx, the whole thing. This black hole is the trachea, and right there are the vocal cords, or the vocal folds. So now sometimes they're breathing and these are opening and closing. Sometimes they're nice and deep and it's just open. Sometimes they're a little light. And in a cat, when I talked about laryngospasm, sometimes these close. And again, you never want to force a tube through these structures. I mean, sometimes you have to kind of push through gently, but if they're closing and fighting you and you push through, you can cause post-op laryngeal edema, and that can cause post-op swelling. So you just want to be careful because these can get very irritated. But that's anatomically, this is what you're looking at. And that's where you're going to aim your endotracheal tube. So they're visualizing here, and then so they've put the tube in, okay, tongue's outside. They've measured the tube. So they've pre-measured, but this is where I usually reach in, and you want to tie it. Let me show you a second. Okay, so I usually, this is very important. You want to try to get your tie. First of all, you have to tie it around the tube, then around the jaw, and you want it to be behind the canines. Because you don't want to tie it right here, because if the tube starts to slide out, sometimes the canines will catch the tube, and then that will actually prevent it from completely sliding out. So you want to be behind the canines. And normally what I would have done at that point is I would reach in and I would feel the trachea and I would slide the tube back and forth. But again, they pre-measured the length, so by doing that measuring on the outside. So then I get the animal in lateral recumbency, and this is where you're going to hook up your breathing system and turn on your oxygen, usually like 1 liter and maybe 2% isoflurane. And then this is how she's inflating the cuff. So you kind of just guess by putting some air in, like, and you're going to blow up some air till you feel a little bit of pressure. Now, there's different ways people do it. So what they're saying here is, oops, sorry. What they do here is they're going to pass the tube. Someone is squeezing, and when you put your head by the tube, if you bag and there's a leak, you're going to hear air kind of come out of the tube. You're going to want to put air in till you cannot hear any air coming out of their mouth, and then you know that the cuff is properly inflated. So she's got to get some air in here to bag. But so she's filling till she doesn't hear any more air. Okay. Okay. Okay, so hopefully that maybe makes a little bit more sense as far as, so normally what you do here, do you have any questions based on that video? And again, we're going to practice when I get you in person, and I think, you'll do some in surgical nursing, but we'll practice like filling a cuff and squeezing the bag. So you'll kind of get practice before surgery of actually doing that in person. But you want to do it fairly rapidly. Again, you don't want to force, if they're fighting you, you just give them a little more induction agent. So if you can't, fully get the tube in on one try, you may have to give more induction, let them sit, and then try again. And then when you put them in lateral, you secure the tube by tying it to the jaw, you inflate the cuff, turn on the oxygen and attach everything. And then this is when you start your monitoring, because now they're under, you're going to, record their heart rate and everything like that. So this is what it looks like. You have to, again, tie it around the tube and then tie it to the jaw. Now in this picture, they've got it tied behind the head. Normally in dogs, I just go right above the jaw, unless they were like a brachycephalic and they literally had no jaw. This is very important as far as the test and also knowing what you're doing. How do you know that your tube is in properly? And there's definite, first of all, you can visualize, you can open the mouth and look, although plenty of times, and there's times I would have bet money that I was in the trachea and it slipped off to the side, especially if they have a really deep throat and you can't sometimes see back there. But if you visualize it, but again, I told you, if you're hooked up to a machine and a bag and they are breathing, their chest is moving, their bag should be moving. So if they're moving air, you're also in the proper place. So they have to move the bag. One thing that I can do is sometimes what I'll do is disconnect the breathing system and put my hand or my face by the tube and I feel them breathe. I feel the air coming out. So you can temporarily disconnect them. Yes, the gas is on, but for a moment, if I'm concerned that the tube is not in, I disconnect and I feel. Do I feel any air coming out the end of the tube? And remember, these clear tubes will fog. So you can also watch and see if when they exhale, is there fogging in the tube? Okay, so fogging, are your unidirectional valves moving? And again, remember that's what controls the flow through, and sorry, I didn't go through the test. I told you I graded it, but I said what controls the flow of gases through an anesthetic system, an anesthetic machine, and that is your unidirectional valves. If you did not have unidirectional valves, then everything would just go in any direction it wanted to. So when they inhale, one should open, and when they exhale, the other one should open. And if they're moving, you're in the trachea. Palpate the neck. This is why I typically I do want everybody to feel. If an animal is intubated correctly, then you should feel so you should feel one tube. The trachea is a rigid structure, and if the tube is in the trachea, you feel one rigid structure. If your tube went into the esophagus, you would feel a rigid trachea, and the esophagus would be rigid. You'd feel two tubes. So you should only feel one tube if an animal is intubated. This is a big one for me. If your patient is vocalizing, I see this with cats, and I had And this happened at VCA. They called me down because they were having trouble. They had anesthetized a cat, and they were like, we can't keep it asleep. We need you to come check this cat. And when I went down there, this cat is laying on a table, and she's sitting on the table, and she's like pawing. She's not completely awake, but as soon as I walked up to her and she's like, "Arr, arr," like she's growling and paddling, I'm like, your tube's not in. And they're like, but you just got here. You haven't even felt anything. I said, if a tube is in the trachea, your patient cannot vocalize because the vocal folds are what makes sound. And if your tube is in the trachea, air is not flowing past the vocal cords. Does that make sense? So if your tube's in the esophagus, that patient is moving that is moving air against their vocal cords. So if you have vocalization, you're not in the right spot right off the bat. I don't even have to look at anything. That's a big, like, not in the right spot. I see that more with cats. Excuse me. If you intubate and they cough, like I am right now, you're probably in the right spot. But again, sometimes I've had people go to put the tube in, the patient coughs and it slips over into the esophagus. So you don't want to rely on that first cough during intubation. You're going to have to you want to check the rest of these things to verify that it did not slip into the wrong spot. And once you guys hook up to the capnograph or the capnometer, when you guys, so in the prep room, I don't think you guys have a capnograph that's in surgery. But when you take them in for a spay and a neuter and you go in the OR, they should be producing CO2. I caught another one at a specialty center I used to work at. They were having trouble with the dog staying asleep. And I walked in and they're like, yeah, this dog's panting, it's going crazy. And I look at the capnograph and the patient's going, it was like a little Yorkie getting a CT scan, and the dog's going, and when I look at the capnograph, there's like almost no movement. There was like a little bit of a slopes, which wasn't really CO2. It was picking up some gas, but I was like, you're not in the trachea. Your tube is not in. And again, they were confused. And I was like, but look at your capnograph. Does it match what your patient is breathing? Your patient is, you should see on your capnograph. You mean, so a capnograph connection, movement of the bag, fogging, unidirectional valves, those are how we know that the tube is in. You have to be able to tell me, how do I know that my tube is in the right spot? So you're going to want to secure the tube to the head, listen for leaks, and usually you bag to 20. I know the video said 18, but usually I just squeeze to 20, and you should be able to hold air by giving a breath without hearing a leak. And then laryngospasm, again, is something that we deal with. Really, we deal with this in calves, so baby cows. We deal with it in pigs, but cats. Cats are prone to laryngospasm, and it can make them very hard to intubate. They can, again, in severe cases, they will spasm shut, and they will not breathe, and they will turn blue. So sometimes what I do, I'll try, if I have a bad laryngospasm, sometimes I squeeze the cat's chest. I try to squeeze and force air out to see if I can get the larynx to open. Sometimes that works. But the way to prevent it, now normally what I do in a cat is, if they've had kitty magic, or say I gave propofol, and when you go to open, I take my laryngoscope and I look back there and I squirt some lidocaine. All you do is you want to squirt it and you want to aim for the epiglottis and the larynx. Sometimes I've seen people just squirt it in the back of their mouth. I'm like, do you even know that got where it's supposed to go? So you want to drip it on the larynx and then wait a second. I've seen people drip it in and then immediately try to intubate. I'm like, it doesn't work that fast. Give it a minute or so. And with cats, it's an aiming. Sometimes cats are doing this, and I've got the tube and I'm literally like, it's like you're almost playing like a video game or something. You're like, okay, now when they open. And what you want to do is use the bevel and get in between their vocal cords. You do not want to force the tube again because you can cause that post-op laryngeodema or swelling. There are some downsides to intubation. None of this would really prevent me from intubating. I think there's way more benefits, but one thing that I worry about is vagal nerve stimulation. So anatomically, you have the trachea, you have the esophagus, and the vagus nerve runs through there to the trunk of the animal. And what happens to the heart rate during vagal stimulation? It either speeds up or slows down.
It increases.
It actually, so it'll drop. And so, well, and I appreciate everyone taking a stab. Bethany's like, I'm not answering any more questions. I always appreciate you taking the stab. If you remember when I was talking about alpha 2s, I said, if I have a patient that has a heart rate of 40, like if I go to check my patient and it's 40, the number one thing I look at is, did they have an alpha 2? If they had dextometor, it's probably from that. The only other thing that really drops the heart rate dramatically is vagal nerve stimulation. So if you had a really difficult intubation, somebody needs to be checking the pulse. Because then if it, say they had a heart rate of 80 to 100, you induce, and then you go to intubate, and then you go to take their heart rate and it's 40. Well, it had been 80 to 100 just a few minutes ago, and now it's 40. And it's a pretty rapid drop. You treat it with atropine, but that sometimes, if you have a difficult intubation, and brachycephalics have a high vagal tone due to their anatomy, so they can be more prone to vagal stimulation. And of course, they're harder to intubate. So I'm always a little more cautious in brachycephalics, or if I have a difficult intubation, you need to check a pulse. You need to check a heart rate, have someone feel the pulse, make sure that it hasn't dropped. So you can get overinflation of the cuff, can cause tracheal irritation or necrosis, or overzealous intubation. If you're having to put a bunch of different tubes in, you can cause that swelling and you may have post-op breathing difficulties. So if I had a hard intubation, I watch those patients a little bit closer on recovery to make sure they're not getting that post-op edema. Now, sometimes the tube can get obstructed with mucus and such. You always want to make sure, it'd be very rare for an animal to have abdominal breathing or increased effort during anesthesia. They're hooked up to a tube, they're hooked up to a machine, they have 100% oxygen. So if I have an animal that starts like abdominally breathing, I'm having trouble with CO2, I always want to make sure I check my tube and make sure that there's no obstruction. Also make sure like your tubing isn't kinked, because sometimes you're doing a dental and you've got them positioned all funky, and sometimes that is difficult. If you wait too long to remove the tube, so the patient gets too light, they could obviously potentially bite it in half and swallow. So that, you know, then you're going fishing, but you just have to watch them. I never, ever, ever, ever walk away from an intubated patient. And I've plenty of times been at school and someone has the animal in recovery, laying in a cage intubated, and they're out like a light. And then they go to go get a thermometer or their pen, or they forgot the chart. And I've seen them walk away from a patient. What if they wake up and fall out of the cage? Or what if they bite their tube in half and swallow it? I never walk away from an intubated patient, or especially an animal in a cage, because you just never know. That's gonna be the I mean, I've had animals that look like they're out like a light and they jump up in about 2 seconds and they're screaming and flailing. So a nice patient wakes up gradually. Sometimes patients go crazy and 1 minute they can fool you. And you just never want that to be, that's the time when you went to go get your thermometer. You need to yell for help, you need to knock on the wall, or you need to make sure you have your materials with you when you go into recovery. So I never, or I say, hey, can you come sit with my patient? while I go get my thermometer. So again, just make sure, because you don't want them to bite it in half. And again, improper cleaning, if you let them sit in the cleaner, we can cause irritation, and then the post-surgical cough can be a problem. So these are all kind of the downsides to intubation that you have to be. And again, the cough, I think I've mentioned this before, because usually you guys talk to the client, you usually discharge the patients. For 1 to 3 days, a cough can be normal, but it should get better each day. It shouldn't get worse. It shouldn't interfere with eating or sleeping or drinking water. So if it's to the point where a dog can't finish a meal, they can't sleep at night, or it seems to be getting worse, potentially there was damage to the trachea, or potentially they've now developed kind of a cough that could turn into a pneumonia. So definitely they need to call the clinic if, you know, but again, it should, again, 1, 2, 3 days, but it should be getting better each day instead of getting worse. So those are things to tell the client. Do you have any questions based on this that we've just talked about?